What is the coronary artery blockage? It's the most common form of coronary artery disease. This takes place by a process called atherosclerosis. So let's watch a video explaining us what it is about.
Let's look at what happens when the coronary arteries are narrowed or blocked and blood flow to the heart muscle is reduced. Blockages in the coronary arteries are usually caused by a buildup of cells, fat, and cholesterol, which is called plaque. As the arteries become blocked, they can't send as much blood and oxygen to the heart muscle. The heart needs blood and the oxygen and nutrients it carries to function properly. When you are active or under stress, the heart needs even more blood. But if the coronary arteries become blocked, there might not be enough blood flow to the heart muscle. This lack of blood and oxygen, which is called ischemia, might cause symptoms like an irregular heart rhythm, shortness of breath, and angina, which is another name for pain, tightness, or pressure in your chest. These symptoms may only last for a few minutes, depending on how much of the heart isn't receiving enough blood. The longer the heart goes without blood and oxygen, the worse the problems might be. Over time, the parts of the heart that don't get enough oxygen can be permanently damaged and die. This is what happens during a heart attack. Longer periods of ischemia can also cause serious irregular heart rhythms and heart failure, which can be fatal.
So thank you for EMED TV. And let's go for our next slide that talks about atherosclerosis. It is a common disorder of the arteries. Fat, cholesterol, and other substances collect in the walls of the artery, as we watched in the last video. Larger accumulations are called atheromas or plaque and can damage artery walls and block blood flow. Severely restricted blood flow in the heart muscle leads to symptoms such as chest pain, and it can develop a coronary disease. How a plaque forms. So let's watch this video talking about how a plaque forms.
The heart is fed by its own circulation, known as the major coronary arteries. These arteries include the left anterior descending artery, the left circumflex coronary artery, and the right coronary artery. The bloodstream contains red blood cells, which deliver oxygen to the heart muscle, known as the myocardium. It also contains fats or lipids, known as low-density lipoproteins, or LDL cholesterol. Atherosclerosis begins when LDL cholesterol accumulates in the arterial wall, forming a plaque. Over time, the plaque becomes larger. Some plaques never obstruct the coronary blood flow. The patient with asymptomatic coronary disease has no chest pain and no myocardial ischemia. A plaque can enlarge to the point that the blood flow is compromised. The patient may have chest pain, but only with exertion. This syndrome is known as stable angina and is not a clinical emergency. Such a patient is still at risk for an acute life-threatening event because the plaque can suddenly rupture, causing clotting of the artery, known as coronary thrombosis. When a thrombotic occlusion is subtotal, an acute coronary syndrome develops, and there are two types. The first type is known as a non-ST segment elevation myocardial infarction, and the second type is known as unstable angina. With these syndromes, the patient experiences chest pain at rest, and the electrocardiogram shows ST segment depression. In contrast, when the thrombus completely occludes the vessel, the myocardium is injured, and the syndrome of ST segment elevation myocardial infarction develops. In summary, patients with coronary artery disease may be asymptomatic, they can have stable angina, or they can suffer an acute atherothrombotic event.
So thank you to the author of this video, And let's go for our next slide that talks about the symptoms of coronary artery disease. The most common symptoms of this disease is angina or chest pain. Angina can be described as a heaviness, pressure, aching, burning, numbness, fullness, squeezing, or painful feeling. It can be mistaken for indigestion or heartburn. Angina is usually felt in the chest, but may also be felt in the left shoulder, arms, neck, back, or jaw. We have other symptoms that can occur with the coronary artery disease. These symptoms are shortness of breath, palpitations, a faster heartbeat, weaknesses or dizziness, nausea, and sweating. Let's watch this video that can explain us better.
So coronary artery disease may not manifest any symptoms. Some patients have no chest pain at all, but on exercise tests or some form of chest testing, there is evidence of lack of oxygen supply to the heart. Another group of patients present with what is called a stable angina, where on exertion, for example, when the person walks very fast, or when he runs, when he climbs stairs, he experiences chest pain, chest discomfort, tightness, or breathing difficulty. We call this a stable angina. The pain or the discomfort is most commonly felt over the chest, can be at the center of the chest, left side of the chest. It can go up to the neck, to the jaw, to the shoulder, to the inner aspect of arm, more commonly left arm than the right arm. And with rest, the symptoms relieve or disappear. And with activity, it might come back. Right? So this is a recurrent episode of chest discomfort. Always gives rise to a warning of a possible underlying coronary artery disease. Another group of patients manifest as a sudden, severe chest pain resulting in what we call a heart attack. So they may not go through a phase of the stable angina before ending up with a heart attack. Some patients, the first manifestation is a heart attack, where the pain is a lot more severe, may be associated with breathing difficulty, sweating, with a severe and persistent chest pain. Under that situation, this particular person should quickly get to the nearest A&E department to seek medical help.
So thank you to the National Heart Center Singapore. Treatment. The treatment for this disease is a therapeutic options for coronary artery disease today are based on three principles. The first one is a medical treatment. It consists in a drug treatment with a cholesterol lowering medication, beta blockers, nitroglycerin, calcium antagonists, etc. The second one is a coronary interventions as angioplasty or coronary stent implantation. The third one is coronary artery bypass grafting. Recent research efforts focus on new angiogenic treatment modalities and various stem cell therapies. So let's watch some videos about the treatment.
If you are diagnosed with CAD, your doctor will consider two approaches to treatment: medical and surgical treatment. The first treatment uses medications such as cholesterol-lowering drugs to reduce the buildup of plaque in the heart's arteries, aspirin or antiplatelet medicines to reduce the blood's tendency to clot and to block arteries, beta blockers to slow the heart, which decrease your heart's need for oxygen, calcium channel blockers, which relax the muscles that surround your coronary arteries and allow more blood to flow to your heart. They also help control high blood pressure. ACE inhibitors, which allow blood to flow from your heart more easily, decreasing your heart's workload. Finally, diuretics lower blood pressure, which decreases the workload on the heart. You may need to take one or more of these drugs every day depending on how advanced your condition is. If your symptoms are severe, your doctor may also recommend surgery to improve the blood flow within your arteries. The most common procedure that you may have heard of is called angioplasty. This procedure is used to open a severe blockage. Here's what happens. A small incision is made near a major blood vessel, so your doctor can insert a tube called a catheter and thread it up towards the blockage. At the end of the catheter is a balloon which is pushed to the spot of the blockage. The balloon is then inflated. Sometimes a wire mesh tube called a stent is put in place to help keep the artery open. Medications embedded in the stent lower your risk of developing a new blockage. If angioplasty doesn't solve the problem, you may need another type of surgery, for example, heart bypass surgery, which creates a new route for blood to flow around the blockage in the artery. Your cardiologist is the best person to evaluate which of these and other treatments are best for you. I hope the information I've given you helps you explore your options with your doctor. And don't be afraid.
Thank you for the Healthy Nation. Now let's see another video about the treatment. Here we have a video from Howard County General Hospital.
My name is Dr. Herzog. I'm a cardiologist with cardiovascular specialists in Central Maryland and Columbia, Maryland, and the Howard County General Hospital, which is a part of Johns Hopkins. So a stent is a small medical device. It's a metal tube with slots in it, which can be pressed onto a balloon and then expanded once it's inside the body. It's used to treat blockages or partial obstructions of coronary arteries. This is typically needed when someone has a restriction to blood flow in the coronary artery, and that can cause symptoms such as chest pain with exertion. The other time in which we use it is when a patient presents with an acute heart attack. And in that instance, the artery is typically blocked by blood clot and underlying cholesterol buildup called plaque. And we open the artery with a balloon and then follow the balloon by implanting a stent, which helps the artery to stay open over a long period of time. The basic problem usually is restriction of blood flow, so that when a patient exercises, they cannot deliver enough blood to their heart muscle, and they feel that as pain or sometimes a shortness of breath. There are generally three options. First, we do a diagnostic angiogram, see how severe a blockage is, how many blockages there are, how many arteries are involved. And depending on those results, we have three options to choose from. First is medical therapy, which can be appropriate if the blockages are not very severe, or if the blockages are not in a place where we can really work on them with angioplasty, but not severe enough that it requires surgery. Second option is stenting, which we talked about already. The third option is bypass surgery, which is generally performed in patients that have 3 arteries with partial blockages, sometimes patients that have complete blockages in certain arteries. Generally, bypass surgery is reserved for those patients that have the most severe disease. It is very successful. It is also more commonly used in patients that have diabetes. procedures are typically performed in larger hospitals, one that have surgeons on site that can do cardiac surgery. The reason for that is there's a very small risk whenever you do a stent or balloon angioplasty that the artery may collapse and we may not be able to get it back open again, and bypass surgery may be required on an emergent or urgent basis. That is rare, and since the advent of stents, it's become much less rare, but still most angioplasty and stenting is still performed in the larger hospitals that have that surgical backup. There is another instance which comes up, which is when patients present with acute heart attacks. And in that instance, the state of Maryland will give us a waiver to perform angioplasty and stenting in the local hospital, even without the surgical backup. In those cases, we make arrangements with larger hospitals for rapid transport if the patient would require bypass.
Treatment of the heart disease is pretty much widely adaptable nowadays, and in the past we have several options such as medication or the bypass surgery, which will bypass some clogged or the occluded artery over the heart vessels surrounding the heart. Nowadays we have some catheter-based treatment which use some balloon dilatation inside from the artery and to treat it. And in old days, we use only the balloon angioplasty, which means that just the dilatation from inside of the occluded vessel. But nowadays, we have a stent, which is a stainless steel metallic cage, which will open up to hold the renarrowing of the vessel. With those modalities, we can see the marked reduction of the restenosis, which is more beneficial for the patient over 2 or 3 years. In the previous years, we have some limitation of the catheter-based technology because even in the most modern technology, such as a drug-eluting stent, which has some drug coated to prevent the restenosis, which can once occurred 20-30% with a bare metal stent, is now reduced the restenosis rate about 5 to 10%. But still, there is a risk of the restenosis, and at the same time, you have to take the medication over 2 or 3 years as an additional care for the blood thinning. Nowadays, we have a more advanced program of the biodegradable stents, which can disappear over 2 or 3 years once it's dilated the occluded vessel and then treated the vessel with stent implantation. And during the 2-year period, those stents.
Diagnosis. For symptomatic patients, a straight echocardiograph can be used to make a diagnosis for obstructive coronary artery disease. The use of echocardiography is now recommended on individuals who are exhibiting no symptoms and otherwise at low risk for developing coronary disease. The next video is going to explain us another diagnosis method. So let's watch and listen it.
First, it's by genetic blood test can determine whether or not there's a blockage in your heart. KPBS Science and Technology reporter Peggy Pico joins me with more on how this simple test could spare patients from invasive medical procedure. So Peggy, what's the traditional way that doctors figure out if there's a blockage in the heart?
One of the most traditional ways is they use an angiogram, and what that is the doctor takes a tube, they thread it up through your aorta into your heart from your thigh, they inject dye, and they actually physically look for a blockage in the heart from that dye.
So that is invasive. I mean, that's definitely invasive.
It is invasive, and it comes with some risk, and some people actually die from it. So it's not a procedure you want to take lightly.
Well, then, so what impact might these new blood tests have on the number of angiograms performed each year?
That's sort of the goal of this new test. There's about 2 million Americans in the U.S. who get an angiogram each year. Several studies have shown that over 60% of those people don't have significant blockage, meaning probably wasn't necessary to do it. More importantly, about 700,000 people who undergo this test have absolutely no blockage. 700,000 people get this risky test that, or could be risky, that basically don't have any blockage and don't need it. So this blood test could change that.
So what it gives them maybe is a feeling of security, but meanwhile they've gone through the angiogram. So let's talk about the blood test, because that's the interesting thing. How will that help doctors decide whether a patient has blockage, artery blockage? I mean, it's just blood.
It's a genetic, they like to call it genomic blood test. They actually look, they take a blood test like a regular blood test, and they actually look at the white blood cells in those tests, and they look at the genes in the white blood cells, and evidently the genes in those white blood cells will react differently if you have a clot or not. So you're talking about a blood test where you look at some things versus an angiogram.
I don't know the answer to this, but I'm curious as to whether there's any differential between the way they test men and test women.
There's not a difference. However, when it comes to angiograms, women by far get unnecessary procedures. And the reason is because they do a whole bunch of tests before they do the angiogram. They'll do a stress test. They put you on a cardio machine and they measure your heart rate. They do all sorts of things. Well, women, it seems, give off false positives. They give off false positives. So it looks like on paper, wow, there's something wrong with your heart. When they go in and look, there's absolutely nothing wrong with the heart. So this would be a perfect test to kind of counterbalance that. Instead, you go get a blood test, and if this blood test showed you had a blockage, then the women could go in. So it would significantly impact how many women are being overprescribed angiogram.
And the fascinating thing for me is that, you're describing all this, giving us information, but you're a local reporter for us in San Diego. So is there a San Diego connection?
There is a San Diego connection. Dr. Eric Topol from Scripps Institute of Science, he did the study on this. He validated an FDA study. And basically what that means is the FDA doesn't necessarily have to have really strict guidelines for diagnostic tests like this. So he went back and said, I'm skeptical. I don't believe this. This isn't going to work. Did a huge study at 30 centers across the country, including Scripps Green Hospital here, and found, wow, it really does work. And now he's an enthusiastic supporter. The study was done here in San Diego, and it's on the market already.
Well, finally, Peggy, people are going to hear this report. They're going to get really interested in pursuing it. When will it be available for the general public?
My understanding is it's made by CardioDX in Palo Alto, and what can happen is your doctor can order it, and they'll need to order it and get the test into the hospital. So basically it'll take patients saying, hey, what about that new genetic blood test? And the doctor saying, hey, I want to order that. But it's available now.
Well, thank you very much, Peggy B.
And that's it. Thank you for watching it.